Good morning. My name is Jenny Doust. I'm a Professor of Clinical Epidemiology at Bond University, and I'll be talking about the breast cancer screening programs in women aged 70 to 74 and what do we know about the benefits and harms of screening. I work as a clinical epidemiologist, so that's someone who looks at trials of new drugs and treatments to try and evaluate whether they work and are effective. And my clinical background is as a general practitioner, and I work as part of the NH and MRC Wiser Healthcare Program grant. So to remind you about what the question is that we're trying to decide, or you're trying to decide, is whether to continue with the current Australian program, which is to invite women and promote screening for breast cancer to women aged 70 to 74 in the government-funded breast cancer screening program. And the alternative would be to revert to the previous screening program, where women weren't invited and screening wasn't promoted to women aged 70 to 74, although they could still access the program at no cost. Now, why are we even having to discuss this as a topic? So the problem is that screening is not always effective, and sometimes the harms of screening can outweigh the benefits. So the benefits are probably more intuitive, so we'll start with those. Screening is beneficial if it detects a cancer earlier than it would be detected otherwise. If there are benefits from giving treatment at an earlier stage of a cancer, because that's going to give you better health outcomes, and if not any of the harms that might happen as a consequence of screening do not outweigh those benefits. What's happened over time is that we've become more aware that some of these harms actually are very important, and increasingly we've recognised that there are harms that come with screening programs. And that's because cancers don't all act in the same way. So I'm going to describe 4 different types of cancers and how screening may or may not help with those different types of cancers. So the first type of cancer is a hummingbird type of cancer, and screening won't work for these types of cancers because they happen too quickly and are too aggressive, and so screening won't actually help you to have a better health outcome. The second type of cancer is, I think, the one that most people have in their mind when they think about a cancer, and that's where the cancer grows slowly. And if you detect that cancer at an earlier stage than when the cancer first starts to cause symptoms, then you're likely to be able to have a treatment which is more effective. And so therefore it would reduce your risk of dying from breast cancer. But there are 2 other kinds of cancer that we've become increasingly aware of over time. So the first is that some cancers are like turtles, and although they would eventually, over given enough time, would start to cause clinical symptoms, these cancers grow so slowly that they don't cause a clinical problem in most people's lifetime, and in fact you're much more likely to die with the cancer than from it. And then fourthly, there are the snail types of cancers. So not all cancers continuously progress. Some cancers grow to a certain stage and then stay at that stage and never progress any further. And so the women who have a snail type cancer, it wouldn't matter how long they lived for, their cancer would never have caused them a clinical problem. So these turtle and snail types of cancers is where the problem of overdiagnosis occurs, and overdiagnosis is very important in understanding the benefits and harms of screening, because when you have a cancer that's overdiagnosed, then the screen detected cancer will be either not growing at all or so slow growing that it would never have caused a medical problem. So it's mostly because of these problems of overdiagnosis that screening programs do harm. So Muir Gray, who's the ex-director of the National Screening Committee in the UK, has this lovely saying about all screening programs do harm, some also do good. So I want you to think of the two biggest problems with screening programs. So the first one is what we've just talked about, which is that when you have a screening program, you pick up a lot of these turtle and snail types of cancers that were never going to harm the patient anyway. And those patients are going to be always harmed by a screening program. They have the diagnosis of breast cancer, which is devastating for them, causes lots of anxiety. They have all the side effects of treatment, and they get no benefit from having that diagnosis. The other type of harm occurs even in women who do get a benefit, and that's because their diagnosis is brought forward in time. And that means even though they can have a benefit from the treatment, it also means that they live with that breast cancer diagnosis for longer. So this is another kind of bias that occurs in screening programs, and that has become increasingly apparent is a type of harm from the breast cancer screening programs. Lastly, and these are probably less important than the overdiagnosis problem, but you also get harms directly as a result of the screening test. So this is an estimate from Jolene Hirsch at Sydney University about the direct harms of the screening test. So this is looking at 1,000 women screened every 2 years for 20 years, and over that time 412 women will need to come back for extra testing. 345 women will need extra testing but no biopsy, and 67 women will need a biopsy as a result of the screening test. And that's because you can't make the diagnosis just based on the screening test, the mammogram, that you need to do further testing to make sure that a woman truly has a breast cancer diagnosis or not. And a proportion of women who get called back for that extra testing turn out not to have breast cancer. Now, it's actually quite difficult to weigh up overall what are the benefits and harms and what is the balance between the benefits and harms. And in fact, this has been controversial for several decades now. And caused considerable debate. So in 2012, the UK government decided to call for an independent review on breast cancer screening, and they invited Sir Michael Marmot, who is actually an Australian but from Imperial College in London, to head a review looking at the breast cancer trials that had been conducted. The review panel consisted of a number of experts, but who had not previously expressed an opinion about whether breast cancer screening was beneficial or harmful. So they looked at the trials of breast cancer screening, and what I'm going to do is to try and summarize the results that they came up with from their review of the putting together all of the breast cancer screening trials. So these are the results from the review that Sir Michael Marmot and his review panel did, and this is based on thinking about 1,000 women aged 50 screened every 2 years for 20 years. So if you had no screening, out of that 1,000 women, 17 women would die from breast cancer. And if you have screening, then 14 women will die from breast cancer in that 20-year period. So over that 20 years, you've prevented 3 deaths from breast cancer. Now, in the screening program, you will have 68 women who've been diagnosed with breast cancer. Now, you can't just simply compare the number of women who are diagnosed with breast cancer in those who've been screened and those who haven't been screened, because of this problem that when you have screening, you bring forward the time when a cancer is detected. So you have to make an adjustment for that timing of the diagnosis. After they've made that adjustment, their estimate of the number of women who were diagnosed is that there would be 13 women who would be overdiagnosed with breast cancer. So to try and sum that up, you screen 1,000 women aged 50 for 20 years. 3 women will benefit because they've had a breast cancer death prevented in that time period. 13 women will be harmed because they've had the diagnosis of a breast cancer that would never have been detected otherwise. And to put that in context, there's 125 deaths from other causes over that 20 years. Now, one of the other things that has been quite controversial is that the trials showed no benefit in terms of the overall deaths. So if you look at overall deaths and not deaths from breast cancer, there was no difference between the women in the screening arms of the trials versus those in the no screening arms of the trials. Now, there are a couple of reasons why that might be, and people have different opinions about this. So some people believe that's just because the trials weren't big enough to be able to detect a difference in overall deaths. But there's another plausible explanation, and that's because the treatments for breast cancer have quite a lot of side effects, and in particular they can have side effects on the heart, what's known as cardiac toxicity. So it's potentially possible that women who have screening may not be dying from breast cancer, but could be dying from the side effects of the treatment. Now, the other thing about the breast cancer trials is that the first screening trial of breast cancer occurred in the 1960s, and a lot of them occurred in the 1970s. So there's actually quite a bit of debate about whether things have got better or worse since a lot of these trials happened. And a lot of people would argue that these are old trials, that our treatments have advanced since the time of the trials, and that our ability to detect which cancers need treatment and the targeting of treatment has improved since these trials were conducted. And in fact, one of the things that the Marmot Review commented on is that one of the things that's had a much bigger effect on improving breast cancer survival is the use of what's called adjuvant therapy. So you may have heard of drugs like tamoxifen or Herceptin, and these are the treatments that are given to women after their initial surgery to try and make sure that the breast cancer doesn't return and to improve the prognosis of women after they've had their initial treatment for breast cancer. So one of the problems is we don't really know what the benefits and harms of screening might be now that we have these better treatments for breast cancer. The trial that is probably closest to treatment in the era of adjuvant therapy is the Canadian trial. So this recruited women in the 1980s, and these women had access to some of the adjuvant therapies that we have now. In fact, the adjuvant therapies have got better since the 1980s. But the Canadian trial had follow-up for 25 years after enrolment. So the blue are the women who did not have breast cancer screening, and the red line is the women who did have breast cancer screening. And you can see that in this trial there was no difference between the all-cause mortality between those who had breast cancer screening and didn't have breast cancer screening in the era of adjuvant therapy. The other thing is that probably our ability to find these turtle and snail cancers, this problem with overdiagnosis, has probably got much worse over time. So 20, 30 years ago, when you did breast cancer screening, you used mammography that was able to detect cancers that were 2 centimeters large. With the current technology that we have, we can now detect cancers down to 0.02 of a centimetre. And so that's about the width of a hair. And what that means is that we find more and more and more of these turtle and snail type cancers, these very small cancers that would never have been detected clinically and would never have caused any problems. So the problem of overdiagnosis has probably got worse over time. One of the things that's often done when talking to women about breast cancer screening is people talk about survival rates. And there are a number of reasons why survival rates can be misleading for women. So the first is that the screening survival rates have got much better over time, but this isn't necessarily due to screening. As I said before, our treatments of breast cancer have got much more effective over time. So if you just compare the survival rates for women 10, 20 years ago with the survival rates for women now, then it will look like the survival has got much better. But that's mainly because the treatment has got better over that time, not because screening is more effective. The second reason is because of this problem that we detect more and more of these turtle and snail types of cancers. So those turtle and snail types of cancers are now being diagnosed with breast cancer. So the way that the survival rates are calculated is they are the number of people who die from the disease divided by the number of people who are diagnosed with the disease. So from the Marmot report, if we take a rough estimate that about 55 women would be diagnosed without screening, and say that 17 women died from breast cancer, then the survival rate is 17 over 55, which is 31%. If we look at the number of people who die in a screening program, so the number of people who are diagnosed is 68, so we've increased that denominator because we have all of these people with these turtle and snail cancers are now included in that, the number of people who are diagnosed. And the number of people who die is 14, so the survival rate goes down, partly because we've improved the number of people who die from cancer has gone down, but it's even more because we now have more people who are diagnosed with cancer, and so that makes the survival rates look like they're improving, even if they aren't. So one of the things that would give us confidence that breast cancer screening was effective would be if you could see that the number of advanced breast cancers was going down over time. Because what that would say is that we're detecting these breast cancers early, the ones that are the bare type cancers, and that's preventing them progressing on to the advanced cancer stage. But if we look at the data, this is data from Victoria and New South Wales, showing you before and after breast cancer screening came in, then it shows you, and it's in Tasmania as well, it shows that in fact the proportion of women who are having these advanced breast cancers has not gone down since mammographic screening was introduced. So what I've been talking about up till now is what we know about women and screening for breast cancer in women between the ages of 50 to 70. What's most important is what do we know about screening for women aged 70 to 74, and in fact the benefits and harms of screening in this age group are even less certain than they are for that 50 to 70-year-old age group that I've been talking about up till now. So there were 3 of those randomized controlled trials that included women in the 70 to 74-year-old age group. When we look at the results for those 70 to 74-year-olds, then it seems like the number of breast cancers is reduced by approximately the same amount in those women as it was in the younger women. So it would look like the benefits of screening seem to be about the same. One of the thoughts was that maybe the overdiagnosis problem would be less in these older women, because maybe in the older age group you'd find more of the bare type of cancers and fewer of the turtle and snail types of cancers. But in countries where they've introduced screening for women aged 70 to 75, then we seem to have this same problem, that the number of advanced cancers doesn't seem to go down after the screening is introduced. So this is data from the Netherlands. The blue line is the women with the early stage of cancer, and you would expect, like you see in that early 2000s, that you get an increase in the early stage of cancer. what you would also expect is that you might see the advanced stage of cancer, which is the red line, that would start to go down. But in fact, there's no evidence that advanced stage cancers has gone down with the introduction of screening for women aged 70 to 75. So this is estimates of the benefits and harms of screening if we extend screening from the 50-70 year age group for another 5 years. So based on this work, which was done by Gemma Jacqueline and others, including Nemet Husseini at the School of Public Health, there will be one extra death from breast cancer that's prevented because of screening for those extra 5 years. And there will be 8 women who will be overdiagnosed, who will be diagnosed with those turtle and snail types of cancers because of the screening over that extra 5 years. Now, to kind of put that in perspective, over the whole 30 years of that time period, out of the 1,000 women, 212 women would die from some other cause. So the other thing to think about in that calculation, that one woman is prevented from dying of breast cancer because of extending this breast cancer screening to that age group, versus the 8 women who will need to be treated for breast cancer who have been overdiagnosed, is when the benefits and harms occur. So for an average woman in Australia who's aged 70, the life expectancy is approximately 20 years. Now, those benefits are going to happen because that woman's prevented from dying of breast cancer. So those benefits will happen in that extra time period that that woman gets to live. So that's at some kind of future point, which would be, say, 5-10 years from the diagnosis. However, the harms are going to happen at the time that the woman is diagnosed. So they happen earlier than the benefits happen. And this becomes increasingly important as you get older, about where the harms and benefits might happen. So something that happens sooner is likely to be more important to women than something that might happen 5-10 years down the track. And again, there's no expected change in the overall deaths. So, as you can see, there is a lot of uncertainty about whether the benefits and harms outweigh each other and if there's clear benefit or clear harm. I think it's clear that everybody wants to avoid breast cancer, and everybody would like for breast cancer numbers to be reduced and the fewer people to die from breast cancer. But screening is a trade-off, and it involves both harms and benefits. And based on the numbers that we have, probably there is some benefit, and the best estimate is around 1 death possibly avoided by screening in that later age group, and some harm, and the best estimate is around 8 women who will be treated for breast cancer that would not have been diagnosed or treated if there was no screening. So thank you. I hope you found that informative, and I welcome any questions.